All right, welcome everyone. This is the DVT session of Probing the Literature put together by ACEP, SAEM, and a group of very committed, wonderful individuals trying to further the abilities of research in point-of-care ultrasound. Today's topic is deep venous thrombosis. We have a couple of wonderful guest lecturers, Dr. Needleman and Dr. Matt Fields, and we look forward to discussing their papers with them. I'm going to go ahead with the screen share, and overall, our agenda is we are going to review the first speaker article and introductions. Then we're going to divide everyone into small groups, discuss the second article in small group, reconvene at around 3:50 to discuss the second group, and at 4 o'clock we will move on to the methods consult. Methods consult is the second hour of our session, where we will take questions, comments, ideas on other research topics and kind of assist with how to make them most feasible, but also as robust as possible. So we look forward to anyone's ideas related to that. All right, so Dr. Laurence Needleman is the Diagnostic Ultrasound Director and Co-Director of Thomas Jefferson's Vascular Center. He's board certified diagnostic radiology. And while he's not an emergency physician, we consider him a friend to the specialty. He has been in practice for 39 years and makes frequent contributions to the vascular ultrasound literature, most recently doing reviews on COVID-19 protocols and imaging assessments for pulmonary embolism in the setting of COVID-19. We welcome his viewpoint as an outsider to emergency medicine, as well as his expertise in DVT ultrasound. Dr. Needleman, it is great to meet you, and we thank you very much for your contributions to this topic.
Thank you very much, and thank you for having me. I will say that I was very close to being an emergency room physician because I am so old that there were no residencies back then. My roommate became an emergency room physician after his internal medicine residency. I went to work in an emergency room in the middle of my residency, and almost stayed on. But to tell you the truth, every time somebody vomited, I actually got sick, and it basically was the warning sign to me that this was probably not my field. So I have to say that I'm a little bit envious of you all for doing this, but one of the neat things about what I do is I get to do lots of different things, as you all know, and having been involved with Jefferson, which has been a teacher of ultrasound for the last 40 or 50 years, believe it or not, we've taught every specialty there is, and my attitude about ultrasound is, if you do it well, you're welcome to the tent. And if you do it not so well, please exit. So with that in mind, I want to talk, I've been asked to talk a few minutes about what we did. And there are different societies, as you well know. And the Society of Radiologists and Ultrasound convene consensus meetings about every 2 or 3 years on topics that are interesting to them. And a few years before this, they contacted me and said, would you be interested in doing a vascular process? And I said, yes. We had done a carotid consensus a few years previously, and I felt that there was a real need for some uniformity among the people who do venous ultrasound, particularly for acute venous disease. And so they gave me the green light. And as with many of these procedures, my thought was to cast a fairly wide net into two groups of people who did the venous ultrasound study and people who interpreted, who took care of the patients. And then there were some members of the group who did both. And so we looked at medicine, surgery, hematology, general internal medicine, emergency room medicine, and radiology, and sonographers, and picked a group of people who had particular interest in this topic. And then John Cronin, who was one of the earlier advocates in the world on venous ultrasound, and I kind of worked out what the plan was. And the plan was basically to start with collecting these people, and we were lucky enough that almost everybody said yes. And then we set up upon us a reading list of about, well, I don't remember how many it was, someplace between 13 and 30 papers. And then we sent out material to others and said, would you be interested in sending us some others? And a few papers got selected in that regard. And so we wound up with a whole bunch of papers that we thought were relevant to the topic, so that when people showed up at this 2-day meeting, they were ready to go. John and I worked out what we thought were the major pieces of the consensus conference, which had to do with, as you see here, patient selection, protocols, sorry.
Yeah, I think the main thing that we got out of it from the point of care point of view was just the specific protocol, because we were getting conflicting data during that period of time on the 2-point versus and like 2-region, depending how you want to define it, protocols versus the extended. And I think this kind of like, this is the protocol, and made it very clear what the expectation was. So I thought that was probably the most important thing for the point of care people, but then also a lot of other elements about follow-up and those other components.
So the two things that we felt were very important that we wanted to make sure of is that we didn't want to totally ignore what happened before. So there was a large consensus in the literature, in the medical literature, in the family practice literature, and frankly, in the emergency room literature, about the idea of pretest probability, D-dimer testing, and some kind of scoring system to use beforehand. And basically, we didn't want to reinvent the wheel. We basically signed on to this. However, we didn't want to be too Pollyanna to know that many people don't get D-dimers when they should, and some people don't get a consistent pretest probability, which involves both a history and a physical exam. So we had to kind of both accept this and move on to that point of what happens when people actually go for the examination. With regard to the emergency room, we had a couple of pieces of information that we thought were important. One of which was, as you alluded to, a bit of poor definition, I think, on what people meant by point of care protocols. And if you go to that, thank you. So the original 2-point compression ultrasound was a non-duplex, non-Doppler technique that was brought out by the medicine group, particularly one particular medicine group that did a really major job of looking at this. And it was defined very clearly as the region from the inguinal ligament to where the femoral and the deep femoral vein come together, and the popliteal vein where you had started to identify the trifurcation vessels. So those were the two areas. I know it evolved to be 2-point, and as we looked at the emergency medicine literature, there were two things that were going on. One was the idea of 2-point truly being 1 point in space, one compression being adequate, which since I've spent a lot of time looking at, probably hundreds of thousands or more veins at this point, I appreciate the fact that, all it takes is a 1 centimeter miss to go and miss something. So we didn't feel that was a point. We wanted to reiterate that this was a region and not a place. There were also people doing some 3 points. It wasn't clear what that was all about. And in addition, Dr. Adhikari, who was from the emergency medicine world, had done some work with looking at the femoral vein. Barbara Hertzberg, who was here many years ago, also looked at the femoral vein. And depending on your patient population, the femoral vein may harbor DVT in a lot of patients, certainly a significant number of patients. So what we had was this knowledge about the femoral vein and the knowledge that even with point of care ultrasound, the quality of the machines are improving even from a few years ago. And with compression ultrasound, we thought it was feasible to be able to go from the inguinal ligament to the popliteal vein for point of care or anybody else. And so, because we were a little nervous about missing that 5 or 6%, we decided to embrace the extended care ultrasound. I will also say that one of the other factors in this had to do with follow-up studies. And the emergency room literature actually was very helpful to us for that, because what it said is that a lot of people who went back to their family doctor, who was told by the emergency room to get a follow-up ultrasound, did not always get an ultrasound. And so now the literature is very clear that a quote limited study, which does not go all the way to the ankle, is not as good as a study which includes the ankle. So the only way to beat that was to do pretest probability in a limited study, to do D-dimer negative in a limited study, or to do 2 limited studies a week apart. And those 2 studies could be extended ultrasound, or they could be any combination of 2-point extended care ultrasound, etc. And so that's also what was a driver for us to make sure that patients who were negative, the message did not come out that that was 100% a negative study. And so those are most of the things that we thought to address in the acute care. We also embraced the idea that it's appropriate to do point of care ultrasound when a complete ultrasound is not available or will frankly take too long.
Yeah, it's very helpful for us because a lot of these patients don't require admission in most cases. And so trying to find ways to send them home safely with anticoagulation if they're positive, and without anticoagulation if they're negative, for us is very obviously important. I also appreciate 2 other elements you mentioned so far. One, putting to bed 2-point, 3-point, the whole point concept is no. That's just a flat out no. So I appreciate that. And then the concept of adding the dimer plus the extended compressive being helpful for a full rule out, I think was also super helpful. One of the questions that I had was kind of going back toward the methods, selection of individuals from all these different specialties is absolutely fantastic. And it's one of the reasons why I specifically wanted to bring you into the fold with our discussion. So we don't want to have just an insular discussion of all emergency medicine people, as fun as that would be. We want to make sure that we're expansive and taking the opinions of others. Was there any conversation about using a modified Delphi model to kind of bring a little bit more statistic validity to the original opinions of the group? Or was the 2-day conference sort of like an already set up model that was kind of already ready to go? Was there a reason for that?
Yeah, the model was one that the SRU has been using now for 20 years, and it's set up some major and some minor articles in literature. What we decided was that we were going to keep talking until we all agreed that everybody in this group that if there was any opinions that needed to be addressed, we would keep on discussing it until it was over. And honestly, some of this material in here was not exactly the way I would have written it if it was just me. But we did stack the deck, in all fairness, by asking Dr. Adhikari to come to the meeting. But I will tell you that before I knew that he had exactly what he had written, he has reviewed for the AIUM in both the journal and for the organization. And I asked so before I knew who he was, I asked the editor of the journal if there were any emergency room physicians he would think about for the panel. And actually, it was his name that came up as a very effective reviewer and a very friend of organized ultrasound. And it was only after he had accepted that I actually knew that he had written on the topic of the femoral vein. So I didn't feel completely like it was stacked to the deck. Maybe the editor stacked the deck, but I didn't know it when I got there. And so we felt that there was enough information that we could get to the point where we could all agree. And even if there were issues that we still don't know about, such as calf vein thrombosis, and the treatment of calf vein thrombosis is still, is clinically still out there. We still felt that we could address an approach to it for imaging, even in the absence of absolute knowledge. So having been on Delphi panels before, this I think was actually a little bit stronger in that everybody had to agree.
Wow, interesting. It's an interesting thought. At this point, I'm going to open up the panel for discussion from anyone else who would like to ask questions for Dr. Needleman. At 25 to 27 after, we're going to move to the beginning of the breakout groups for the second article. So any further, or I'm going to open it up to questions from anyone else.
I guess I'll start. This is Josh Gutman. I'm ultra faculty at Emory. I just wanted your opinion regarding what you think color and spectral Doppler truly add to the diagnosis of DVT. Does augmentation and respiratory variation really add a lot that you think we should be doing this routinely on our point of care ultrasounds? Or in my conversations with other radiologists, they don't seem to think it adds too much. So I was looking for your opinion.
So we're stuck with a billing issue, frankly, that the way that ultrasound got created was via Doppler first and then imaging second. So the billing code for Doppler is a duplex code, which, by the way, is a triplex code, because at some point the billing people said that spectral Doppler and grayscale is not enough. You have to add color to it. So let me just say that from the point of view of how societies will do this, if I were in Europe, I probably would not be doing Doppler. Having said that, there are specific times when color is particularly helpful, which is when you don't see things very well or you're not sure what structure you're looking at. There are some nice articles, and one of them is referenced in there about what constitutes a limited study. And there are some parts of the body that are hard to see, like the Hunter's Canal, the distal femoral. And sometimes you can kind of think you see everything well. If you can get a good color filling, that can make you quite confident that you're dealing with a normal vein there. So color, I think, is most helpful, frankly, for some problem cases. The spectral Doppler is a more interesting question because it started the whole ball of growling. And there is the common femoral or iliac vein is what's recommended in the practice parameters of Doppler. And we think it's helpful for looking at upstream obstruction, pelvic vein obstruction, pelvic masses, even pregnant uteruses. And that's where probably most of the value comes in my mind for that. Looking at asymmetry, which would suggest how much asymmetry is important is there. So rather than kind of get into it besides recommending as part of the complete protocol. It was also mentioned the idea of worrying about iliofemoral thrombosis comes from two different places. One, the vascular surgeon who felt that the paradigm for thrombolysis is moving towards thrombolytic therapy, and so that it's going to be more important in the future to make that diagnosis. And two, to be mindful of iliofemoral or iliocaval thrombosis, and to be liberal about getting imaging, whether it's CT, pelvic ultrasound, or MR. But you're right. And as for augmentation, there's a very good article that augmentation has never helped. So we do not augment for spectral Doppler. Sometimes I'll augment in color Doppler if I have trouble filling a vessel. And kind of that's the major time, probably the only time you'll see me augment someone.
That is fantastic news. I have been fighting that augmentation is garbage for a couple of years, but I didn't have good data to say so. That feels so validating.
So it's referenced in the ACR guidelines. It may be referenced in here, and it was out of the University of Alabama. So you're from Emory. I know it's not quite Alabama, but for a New Yorker, it's all down there anyhow.
I'm a former New Yorker.
Okay, good for you.
All right, I think we have time for maybe one more question, then we're going to break out into the breakout rooms.
I had a question along the same lines of like what radiology does that we do differently is that we usually don't look at the calf veins thinking that it's because it's not a deep vein, it's not clinically significant. What do you think of this, and what's your opinion on whether we should be doing that or not?
So couple of things. First of all, actually, the calf veins are deep veins, posterior tibial, perineal, even the soleal and the gastroc are deep veins. And in fact, they probably harbor more DVT than the upper extremity veins if you were to actually look at everything. So they are the beginning of the disease, if you will. That's where, when you have stasis, that's where clot begins. So our feeling about why the complete exam is important is, why would you ignore the earliest clot, which is available? However, as you know, we're also expected to find actionable information. And there's very little good data that you have to act on deep venous thrombosis immediately. There are some criteria for treating them, but it's not to prevent pulmonary embolism. As a rule, all clot will embolize, but big clot that cause PE is thought to come from the bigger veins. So the issue is not to necessarily get it in the acute setting, but to kind of cast your net widely so that if it propagates over the next few days, you'll pick it up on the second scan. So I think it's a hard part of the test, particularly with swelling, and it at least doubles the time. I don't think some people say it's 15 minutes per side. I think if you do it a lot, it's doable. But again, it's a lot of work for something which you may, then you have to deal with the idea of treating them or following them, et cetera, et cetera. So again, we acknowledge that it's important to get a comprehensive picture, but in the acute setting, we don't think that that's important.
Wonderful. Thank you again very much, Dr. Needleman. We really appreciate your time spending with us. If you have any closing major thoughts that you want to make sure that every emergency attending, every emergency provider out there was to know, how would you boil it down to a couple of words?
I would say that when I experience, and use your imaging people, whether it's a radiologist or vascular medicine, vascular surgery, learn how to do it, check out your results. When you don't know what you're looking at, call for help. Everybody loves to be asked for help. Radiologists even like to be asked for help. So, and the more you see, and the more you can do. So I think that's true of anything in ultrasound, and particularly true in this topic.
Awesome. Well, Sarah, thank you very much for your time. We're going to break out into our breakout rooms at this point, and then I will see you guys again around 2:50 to review article number 2. Thank you, guys.
Thank you so much. Bye-bye.
Welcome back, everybody. We've just reviewed the second article, and we're going to take some comments and thoughts from our group moderators and some of the individuals in our small groups. So I'm going to ask Monica to take it away.
So one point that our group brought up is the difference from the 2-point compression to the extended proximal. It's not really much different, meaning that you already have that area exposed, you know where you're starting and you know where you're ending. So adding, just like we would talk about with a fast exam and looking at Morrison's pouch, the caudal tip of the liver, and more dynamic images for ruling out that fluid in the right upper quadrant, the same thing we can do for the DVT, meaning it's going to be very minimal effort to add to that actual exam to be able to see the proximal fem and to see if there's any thrombosis in there.
Very good point. I mean, there were some articles from, I think back in like 2011, they were looking at residents, and they said that the average resident can perform the scan in under 3.5 minutes. And that was bilateral DVT ultrasound. And then I'm just going to kind of open things up to everyone else for further comments.
Everybody, our group kind of had similar comments that it really doesn't add that much to do that. So why not? And I feel like it's rare, at least, I'm at the same facility as Dan up in Buffalo. We really don't teach that it's just a single point, it's a whole region. And we basically tell the residents, see as much as you possibly can in that thigh, and just see as much as you can in that thigh until you can't see it anymore. And same thing on the calf. We don't tell people to go too far down in the calf, just because, again, it's clinically not as significant, significant to change what we're going to do. But why not extend down to that calf? There's really no reason not to.
Agreed. And Mike, thank you very much for the reference there. Appreciate it. I'm actually going to interrupt things for a hot second. Matt Fields is actually one of the co-authors on this study. Hopefully everyone kind of noticed that, and was wondering if he had any thoughts about the journey to this article and maybe some, anecdotes or stories that were related to publishing this.
Thanks, Dan. Yeah, I'm like the last author on it, so a lot of times I probably just get truncated, which is okay. I have to give most of the credit to Shrikar, who started this work, but I guess he's going to be here today, so I'm going to stand in and share some of the kind of story behind this paper, which is kind of an interesting story, I think, for fellows. And I think my past fellow, who is now an ultrasound director himself, Chris Tom, is maybe on. He was on earlier. So I don't see him now. But Chris, if you're on, please correct me if I get any of the details wrong, because it's been a few years since we did this. But this actually, the story behind this paper is that Chris was my fellow at Jefferson, and he was doing his thing that fellows do. He was in the department, he was scanning, he was practicing clinically, and he was doing DVT scans. He was building his confidence. And then he had a case where he did, and at this point in time, you have to understand that the Bernardi article, the JAMA Bernardi article, it came out, and we were kind of embracing that in point of care ultrasound, that 2-point limited compression ultrasound was acceptable for rule out. And a lot of us were learning that, and I had been taught that. And so I was teaching that as well. And so I'm partially to blame for this, but he had a case, he did the scan, and he sent somebody home and missed a femoral, at the time we called it superficial femoral. Fortunately, that nomenclature has changed to just femoral, isolated femoral DVT. Very upset about it, and we found out from the bounce back and everything, and embarrassing for him and for us, and so became like this immediate obvious QA project, which is like, how often does this happen? And I would say to the fellows out there, if you're looking for a research project, QA projects are a way to start your fellowship, your research project. That's where every interesting question starts with a good QA. And so that's what we started to do. But of course, I, trying to save him a little bit of labor, I was like, well, look, man, let's do a lit search, right? Like, let's see what's out there. So he started looking into it, and he managed to figure out that Shrikar had done this exact same, looked into the same question and published it as an abstract, I think for AIUM, and managed to find it somewhere on some website that I think maybe it was the AIUM website, that he'd actually done some of this data. And I was like, well, instead of reinventing the wheel, let's reach out to Shrikar. And this is where it's very important to network, right? That's the key to success, is networking in your career and fellowship. So, 2 parts already to getting to success was, QA and then networking. And we reached out to Shrikar, and Shrikar told us, like, yeah, I did this. I tried to submit it, it got rejected. And I kind of, put it on the back burner, but he had discovered this 6%, thing. And we believe that was very real, because we had experienced it ourselves. And we were actually, in the meantime, starting to actually pull the data at Jefferson. So we brought new energy into it. Chris and I took on a lot of the work that he had done. We revisited it and we kind of brought breathed some new energy into it, and new momentum. And we all worked together and kind of rewrote it and relooked at the data, and we were able to submit it and get it accepted for publication. And it was one of those things where I think the message and the finding was so important. It's not often you get a retrospective study accepted to Annals and published in Annals, but I think that the one of the editors just found that data point so interesting and so important that they took it. And so I just kind of like to tell that story, because I think it brings up a lot of good points for fellows and projects you're looking for to really take that kind of a QA approach and networking approach. Just some general comments about DVT ultrasound and kind of take home messages for this. I think it was kind of brought up before, but I think one of the big issues for DVT ultrasound, a couple of big issues for DVT ultrasound, is one, it is one of the few modalities where we are, as emergency physicians, doing a test that is going to be a rule out test for a disease process that could potentially immediately kill somebody, right? And so that makes it scary, right? So that makes it scary. So there's a lot of our colleagues out there that won't do this modality. They are frightened. And so I think why it was very important for us to kind of get this right as a specialty. And, because we had heard anecdotal stories of missing it. We actually did a literature review ourselves at Jefferson. And I actually have some unpublished data that I need to finish, just like Shrikar didn't finish his, which is that we actually found a 5% rate of isolate, what we call atypical DVTs, ones that don't cause the common femoral, the popliteal. And one of the findings that we also looked at with that was like, what kind of signs or symptoms were more frequent. And one thing that we did find in that our retrospective analysis was that isolated thigh pain did have a stronger association with those isolated femoral DVTs. So something to help prompt people to investigate more is whenever you have those cases of that really focal thigh pain. And then, but then I think just understanding the terminology, I think that was one of the big values of this paper, was that it really started a conversation around understanding as a specialty emergency medicine, the terminology we're using, whether it's like single point compression or regions, or we're doing like entire spans. And I don't think it's our fault that we didn't have that terminology always correct, or that a lot of us didn't have it correct. I think that there's inconsistency in the vascular surgery radiology literature. When you look back at the original Lensing New England Journal article from 1989 describing 2-point limited compression, it really sounds like it's a point when you read it. You have to like really read it thoroughly to understand that they may have been like looking more than a point. And then you look at other papers that have different descriptions. And so I think there's just been a lot of variability in this. And so I think it really is important for us to really be very deliberate when we talk about this, but also make people understand that every centimeter you press and you scan, the more you scan in that vein, the more you're increasing your sensitivity, right? So it's like, if you can do the whole vein, you're going to get to that close to 100%, but every little centimeter you go, so whether it's 2 point, 3 point, 5 point, every little bit you go to really kind of reinforce that. And then, I think that was kind of, I think all the comments I wanted to make, and just honored to be here. I know that I don't think I can live up to the awesomeness of Shrikar, and I'm sure he had a lot of more valuable insights to share. But what I will also encourage everybody here, every fellow, every aspiring fellow, is to get to know Shrikar, because he will help you with your career
And how to grow a really
be
awesome
successful.
mustache.
Yeah,
Us baby-faced guys can't really match up to that anywhere near as close.
I tried growing a Shrikar mustache, and it looked horrible. I looked like some kind of like bad Mario character. It was
State trooper. It's 4:01, so I'm gonna say that, if you need to go, feel free to head out. For those who want to stay for methods consults and further discussion with Matt, I would welcome you to stick around. Matt, I really appreciate the story of that case where you had a fellow who had that femoral miss. That really lends kind of like an emotive component to everything, which I think is really important. So Matt, if you had any further comments, we're after the time and we'll start the methods consult in a couple of minutes, but if you had any further comments, feel free to go for it.
No, if anybody has any questions, I'm happy to field anything. But yeah, keep this is great. This is awesome that you guys have organized this these probing the literature sessions. So very cool.
Yeah, we're having a lot of fun. I think your point about like these are great QA projects for like a lot of us have that either QPath or some middleware that stores everything, and it's just the library of data that's ready to be queried and have good clinical questions asked of it is that's exactly why we're here.
Yeah, and that actually reminds me, the other thing I did want to say is that before you do launch into a retrospective study, or like any kind of because a lot of times if you're doing a QA study on your database, it's retrospective, just make sure that you go to I like to go to Animals of Emergency Medicine and look at their guidelines for submission. You don't necessarily have to submit it there, but they have a good description of the standards that you should follow for every study type. Just so like you're doing retrospective study, you want to make sure that you have a good setup with data abstraction tools, and that you kind of perform iterative reliability on your abstraction techniques and things like that. Because sometimes if you start just jumping in and looking up, start making a database and you don't do it formally, you're wasting your time and you're spinning wheels. It's going to be hard to publish that later if you haven't followed standards for retrospective research. So somebody just posted for me. So the strobe checklist, thank you. So that's what I'm referring to. So yeah, just always make that quick look. And I think it also helps you to understand the whole process of submission, and thinking about that from before you even start is smart. And you should talk to your ultrasound director or your fellowship director about that before you start spending a lot of sweat equity.
Awesome, appreciate that. I'm going to stop the recording at this point and open it up to